Thank you, Linda. I appreciate that. The title of Practice Transformation Manager encompasses a lot of things. So at the state, we have many different roles. So probably sounds better than it actually is. It just means I do a lot of stuff. So thank you for inviting me, Linda and Bud. I really, really have enjoyed my time here and learning what everybody out in the audience is doing. You guys are doing some great stuff. Great things. I'm doing a lot of stuff. You guys are doing great things. But first of all, I want to tell you a little bit about Washington State. You saw my colleagues here. They're doing a lot of great things as well. But Washington State is, we like to think, a little unique. First of all, it's the only state that you have to say state afterwards, so people don't get confused where you're from. I heard Kathleen say state about 5 times. We'd like to just say Washington. I moved there in 2000 and would tell everybody, oh, I'm from Washington. They're like, oh, you work in the nation's capital. No, it's the state. Pacific Northwest, oh yeah, that Washington. So it's kind of a mysterious place. No, it doesn't rain all the time. Unless you're thinking about moving there, then yes, it does rain all the time because the traffic's getting really bad. No, I'm just kidding. It's great. I know Amy knows what I'm talking about because Oregon's getting pretty crowded too. But no, we love our state and we love the Pacific Northwest. A lot of innovation up there, a lot of great people there, a lot of really good thinkers. Yes, you can blame us for never being able to order coffee in the same way again because there's a Starbucks on every corner. You can't say large coffee anymore. It's venti, macchiato, whatever. But you can definitely say that, you now can order anything you want online in your pajamas because of Amazon. Maybe that's a good thing, maybe it's not a good thing, I don't know, because Jeff Bezos is now gonna transform healthcare. Not sure how we feel about that, but at least he did hire somebody who knows something about healthcare, so we're gonna wait and see how that all pans out. Microsoft, so we think we have a lot of innovative thinkers in Washington State. I don't know if it's, again, the rain that causes us to be fearless or just stupid, I'm not sure, but I feel pretty happy about where I live. We have very supportive policymakers in the Northwest who say, sure, go ahead, try it. If you fail, we don't want to take any credit for that, but it's okay, go ahead and try it. And we get a lot of outside folks saying, we really like what you're doing in the Northwest, so we're going to support you in your efforts. So that's Washington State. A lot of collaboration going on. You heard about our Honoring Choices Pacific Northwest doing great stuff. So what we're doing at the Healthcare Authority is we have really committed to spreading shared decision-making as practice in our state. And we received a grant, a Centers for Medicaid Medicare Innovation grant several years ago, 2014. And part of that grant was to test out new payment models, but also to increase patient engagement and awareness and empower patients and families to really work with their providers to increase the shared decision-making experience. And so along with that, we have developed a certification process. And so just to ground you a little bit in how we look at shared decision-making, our favorite definition of shared decision-making is one from the National Learning Consortium of the Health IT. And this is the one that we like because of the words that are highlighted in red. Because we feel that clinicians and patients should work together to make decisions based on clinical evidence, and really that balances risks and expected outcomes with patient preferences and values. We've heard a lot in this conference about patients' preferences and values. That's really important to us in Washington State. So when we think about shared decision-making, this is really what we are trying to get at. This is the core of what we think about patient decision-making. So I know we've shared a lot of stories at this conference, so bear with me. I'm going to share this story about why this is really important. So Sue is a 65-year-old female. otherwise known as Susan, Susie, Mom, by her 3 sons, little monsters. That's not my definition, that's my husband's definition. She was my mother-in-law. So she was a 65-year-old female diagnosed with cardiovascular disease after a long illness with pneumonia that went into her heart. And she wasn't eligible for heart transplant because once you hit 65, you're no longer eligible. I guess they decide you're too old or something. I don't know what that is, but that's the protocol. So she became very ill and went into the hospital. She had a 70% blockage, and her heart was functioning at 12 to 15%. So she had to make some decisions. She had some choices in front of her. Of course, she went into the hospital on the weekend, and her cardiologist was on vacation. That seems to happen sometimes. And so the decision put before her and her family was whether to have an LVAD, a left ventricle assist device, which is basically a mechanical pump for the heart, or not. Those were her 2 choices. So when the cardiologist on staff presented that information to my husband, who was the oldest son of 3, he said, well, what does that mean? And he said, well, it'll keep her alive a little bit longer. He goes, well, how much longer? He said, well, that depends on your mom. He goes, but what does that mean? He said, of course I want to keep my mom alive longer. He said, well, what about her quality of life? And he said, well, that's hard to tell. He goes, well, that's not much information to go on. And so she was on a ventilator, but she was still aware of what was going on. She was already taking 35 medications a day. It's a lot of medications, but she was still able to get around a little bit, still able to do the things that she liked to do, but she was a lot slower. So my husband called me and he said, I'm not really sure what to do. And I said, well, are you asking the right questions? And this was long before I ever knew anything about shared decision-making or patient decision aids. And he said, well, yeah, I asked him what this means. And I said, but are you asking the right questions? He said, well, what do you mean? I said, what is your mother going to be able to do with this device? And he said, well, I don't understand the question. And I said, what does your mother really like to do? What's her one passion in life? The thing she's worked for her whole life. He said, well, gardening. You see her house, she has flowers all over the place. And I said, exactly. I said, that's the question you need to ask. So he tracked down the doctor. And he said, will she be able to garden? Well, I don't know. Will she be able to garden? Took him about 3 or 4 times to really get the doctor to answer the question. And he finally did. And he said, no. He said, she'll have a lot of doctor's visits, and she'll be on a lot more medications. He said, more than 35? He said, it's possible. He said, okay. I said, now take that information to your mother. See if she understands it. And she did. Sorry, this always happens. He said, okay, Mom, now what do you want to do? Do you understand what this means for your life, for your future? He said, you will live longer, but you will probably spend a lot of your time in a chair, watching TV, sitting inside. And this was northern Idaho, so the winters were pretty harsh, but the summers were great. And she said, I understand. And he said, do you want to have this procedure? Emphatically shook her head no. Because one thing about Sue, she's very stubborn, she's very proud, she believes in justice, she will give her last coat to somebody who needs it beside herself, but she knew what she wanted in that moment in time, and she understood the question. And she gave the answer based on her personal preference and her choice. So my husband brought the doctor in. He said, tell the doctor what you want. She couldn't speak very much, but she said, no, I do not want this. So they brought her family in, and they took her off the ventilator, and she passed away peacefully with her family around a couple days later. That's what she wanted. Maybe her family didn't want that, but that's what she wanted. And she lived her life the way she wanted. And so the nurse said to my husband, she said, you know what? You were very lucky She said, you may not understand today, tomorrow, next week, or maybe not even next year. But she made the choice for herself. You did not have that burden on you. She said, I had a couple brothers in here yesterday fist fighting because one wanted to keep mom alive and the other wanted to honor mom's choices. So that's really what this is all about. It's about honoring the choices of the patient in that moment in time. The one thing about Sue, she was very stubborn. So the year before that, when she had a pacemaker put in, my husband went out and spent 2 weeks with her, and I said, you need to talk to her about what she wants if something happens. And he tried. All she wanted to do was canned peaches. She won't do it. I said, just keep trying. Nope, just wants to can peaches. So she's stubborn. So he has 1 jar of peaches left from his mom that she canned in 2009. He's never going to eat those peaches. It's probably going to be passed down through numerous, some year, somebody's going to pick up these peaches and go, where did these peaches come from? Nobody's going to know, but he's not going to get rid of those peaches. So anyway, I tell that story because the power of choice is so important, very important. So that story just illustrates how we're all faced with choices every day, some easier than others. I mean, this is an easy choice. Do you prefer blue or red M&Ms? I don't know. But we're all faced with choices, some easier than others. But choices are very powerful things, and they're very personal things. So there's a saying by Nelson Mandela that says, may your choices reflect your hopes and not your fears. And so hopefully we're able to make those choices at a time when we really understand what our hopes are and not our fears. And not what our family wants. A lot of people do make those choices based on what they think our family wants. So think about what drives your decisions, what drives your choices. When you go to a restaurant or your favorite coffee shop, do you let them make your decisions for you? Do they hand you a coffee and say, I think this is what you need today? No. So why should that be different in healthcare? I know it's not apples to apples, I get that. And I think, your barista has a little less education than your provider, your doctor. But it's still about personal choice at the end of the day. So we make a lot of choices in healthcare. We make choices in healthcare. I know there's providers out here, people who provide a lot of healthcare, but everybody in this room, I will guess, has been a patient at one time or another. So everybody in this room has had to make a choice about their health care at one time or another. But what it all comes down to is the same thing, personal preferences and values. So when we've made those choices in healthcare, there's been a couple studies about this. And what they found is patients make a surprisingly large number of decisions related to their health care every year. Again, some smaller. Should I get my flu shot? Should I not? I personally think that's a very large decision, and yes, you should get your flu shot if you haven't already. Sorry, public health background. So in this study, they found that 82% of adults over the age of 40 have made a medical decision in the past 2 years. And of those, 54% of those adults have faced 2 or more of these types of decisions. But when asked about 9 major medical decisions, patients on average knew less than half of the critical information. But why does it matter? Well, a third of medical decisions have 2 or more treatment options. Not whether or not to have a flu shot. You could say that's 2 choices, to do it or not to do it. But when we say there's 2 or more treatment options, that's when you're faced with a decision that you have more than one choice, including the choice to do nothing, where there is no right course of action. The course of action is what's right for you as the patient, or the family member helping your loved one make the right choice for them. So in order to help you or your family member make that choice, you need to be fully informed and have all of the information to help you make that right choice with your provider. And so one way to do that is through shared decision-making and also with the use of tools such as patient decision aids. So I'm going to show you one more study around consumer attitudes towards shared decision-making. Do they even know about it? Do they feel it's important? So consumer attitudes towards decision making. So this study, what this shows is that, surprisingly enough, the largest percentage stated that they prefer that the patient should decide with some doctor input, which is good, but followed fairly closely by patient and doctor decide jointly. Does everybody agree that that's important? Do they agree one's more important than the other? I mean, I think that this is a good reflection of what we want to see happen. But yet, shared decision-making still isn't universally practiced. But why do we think it's important? I mean, we know it's important. This is kind of tongue-in-cheek. I love this picture. I think this is great. But in all seriousness, shared decision-making is important for several reasons. It honors the patient's personal choices, which we've talked a lot about that. It reduces variation. What that means is some patients are more likely to get care that maybe they don't need, or maybe they don't even want. Or there may be patients who don't get care that they need and they want. So what shared decision-making can do is it can kind of level that playing field a little bit. And there's been a lot of studies on this, and I'll talk about that in a little while, a little bit more. But it also increases patient safety. It supports informed consent. In Washington State, we have laws that provide that if providers use shared decision-making and certified patient decision aids, they have a higher level of protection against informed consent laws, because it assumes that informed consent has been achieved. They have to document it in the record that they've done shared decision-making and they've used a certified decision aid with the patient, and that they've received signed consent. Sorry, I'm not saying this really well. But they receive a higher level of protection. So if something should go wrong in a procedure and a patient, there's a malpractice suit, the patient has a higher level of burden to prove that they were not adequately informed. Now, when we talk to providers and say, look, here's a carrot for you to do this work, they say, well, that's great, but we still think it's important work, so we're going to do it anyway, which is actually really great. And shared decision-making, lastly, it's really a key component of, and I'm going to change this to person-centered care, because we've talked about this a lot this year, looking at Carol. Is patient, but we're going to change that to person now. So it is a key component of person-centered care. So when we think about person-centered care, the definition that I love is from the Institute of Medicine, because everything about this definition just speaks to what we're doing. Patient values is in here twice. So this is why we just love this definition. So thrilled when I found this definition. So I'm going to tell you one more quick story. When you think about patient-centered or person-centered care, it's really about people, right? And I know we've heard this throughout this conference, so I know I'm preaching to the choir here. But I'm going to tell you a really quick story about Mary. Mary was my grandmother. I know I put case on here. I was trying to keep it impersonal, but it's hard to do that. She was 98 years old, very healthy. Towards the end of her life, she was diagnosed with dementia, still very physical though. She had kidney cancer. She was living on one kidney for about 30 years, but she was tough. We come from a long line of tough women in our family, diagnosed with dementia. Was getting ready to go out to dinner. She suffered a stroke. And she's living in Colorado, and I was in Washington State at the time. And just to make that clear. And so she was taken as stroke protocol to the nearest hospital. It was a teaching hospital in Denver. They have a lot of those in Denver. I don't know why, but good thing. And my grandmother, she's very Catholic, very prepared. She had her living will, she had her DNR, she had prayer cards for when she passed away. She had it all paid for and taken care of. So my aunt inherently knew what her wishes were. But she still felt bad. She calls me and she says, these doctors are all coming in here and giving me all these options. But I don't think we should put a feeding tube in her, but they keep telling me we should put a feeding tube in her. I said, are they telling you or are they asking you as an option? She says, well, I'm not really sure, but I feel guilty. I feel like I'm starving her. I said, is that what they're saying? She's like, I don't think so, but I really feel like they're making me feel like I should do this. I said, what did she want? Well, no, she didn't want this. And I said, well, then you should probably honor that, right? Yeah, I know, but I still really feel like, they're really making me feel like, and these different doctors are coming in here. And I said, okay, well. So she calls her friend, Sister Rita. Sister Rita was a very strong-willed person. She comes in and says, don't you dare put that feeding tube in her. You know that's not what she wants. 98 years old, didn't see very well, didn't hear very well. Quality of life was not great. But she loved to go to dinner, so I guess she was still doing great. And that's what my aunt said. She said, well, we were getting ready to go to dinner. Do you think she might be hungry? And I said, I think she's probably okay. And I said, you have to do what she wants you to do. So she fussed for about 3 or 4 days, and she says, don't come out yet, because my mother had passed away in February, and we had planned a memorial service for her a few days later, actually, because the ground was frozen in Colorado. So we had cremated her, and we were going to bury her a few days later. So my grandma, because she was very practical, decided it was her time to go, so we could have a dual ceremony. Thank you, Grandma. Actually worked out. Finally, sorry, that was a aside. Finally, an older doctor came in one day, and my aunt just was beside herself. She said, what would you do? He said, well, as a doctor, we're taught to heal and give options. And he said, but as a son, I would do what she wants me to do. And so she was relieved. The burden was off of her as a daughter. She said, okay. So they took her to hospice, where she passed away peacefully a couple days later with her family around. But it was so hard for her. She doesn't work in healthcare. She didn't know what to do, even though my grandmother had done everything, unlike my mother-in-law who did nothing. And, it was kind of a teachable moment for the doctors and there. It's like, help these families. Help them. But as patients and family members, you have to help yourself too. I really think it's important to help yourself. So when you think about patient-centered care, here's a diagram that I love. So researchers from the Harvard Medical School, on behalf, and I promise I have no more stories, on behalf of the Harvard Medical School, on behalf of the Picker Institute and the Commonwealth Fund, defined 8 primary dimensions of patient-centered care. They found that there are certain practices conducive to positive patient experience, and their findings form the Picker's 8 principles of patient-centered care. They said patient, I'll call it person. So the ones in 4, I've highlighted those because those are really what make up the core of shared decision-making. But I'm going to focus on information and education for a second. A few minutes ago, I mentioned that it's really important for families and patients to get the information they need to make an informed decision. And so one of the ways that we can do that are through patient decision aids. So patient decision aids are a tool that providers can use in shared decision-making to engage patients in those conversations by giving them the information they need to make the right choice for themselves. Now, this information includes the risks versus the benefits. It should also elicit conversations about their values and their personal preferences. And it comes in many different forms. It can be a written document, it can be a link to an interactive website, it can be videos, it can be visual aids. But the one you see on here is the one that we recently certified by Respecting Choices on CPR, whether to have or have not CPR. Now, decision aid supports shared decision-making. It's a tool. It is not shared decision-making. And that is something that is confusing to people sometimes. Shared decision-making is the act. It's the process of engaging the patient in the discussion. The decision aid supports shared decision-making. Can you have shared decision-making without patient decision aids? Of course, you can. But the decision aids really help with that process. So there's been a lot of studies about decision aids and the use of them and the evidence. This is based on a Cochrane review that shows that decision aids increase knowledge of options. They provide a more accurate assessment of risk perceptions. They lower the conflict about decisions. They increase choices that are more consistent with values. They provide greater participation in decision making. And they also lead to fewer patients choosing major surgery. So that tells us that maybe those patients didn't need that surgery or didn't actually want that surgery. And here's another study that's a little closer to home. Group Health Research Institute, or Group Health, it's now Kaiser Northwest, they did a shared decision-making pilot back in 2009, and they also did a similar survey, and they found very similar, they had very similar outcomes. So there's a lot of work going on right now around shared decision-making, but I think if you were in the training the first day with Linda and Carol, you heard that shared decision-making is not a new concept. It's actually been around since the early 80s when there was a national presidential commission to promote national adoption of shared decision-making. And since then, hundreds of decision aids have been developed by numerous developers. Unfortunately, uptake has been very slow for lots of reasons. Attitudes about shared decision-making and assumptions about what it is has been a barrier. A lot of providers think they already do it just by having a conversation with their patients. And they find after they go through a training, they're like, oh, I guess I actually wasn't doing shared decision-making. I was just having a conversation. Some think it's not really as important as we think it is, which that's too bad. We'll keep training and trying. Lack of incentives. Lack of time to do good shared decision-making. And also a lack of high-quality decision aids to support good shared decision-making. So more recently, in 2010, in the Affordable Care Act, shared decision-making showed up again. Of course, federal government, there was no money tied to it. Pretty typical. 2015, however, CMS did put a benefit for shared decision-making in a Medicare benefit. So if a provider provides shared decision-making to Medicare beneficiaries, there's 3 different health conditions. They do get paid for actually doing shared decision-making. I think it's like 15 minutes. But it's only for 3 very narrow health conditions. But it's a start. And then in 2016, the National Quality Forum brought together experts in the field of shared decision-making in other areas, Bud was at that meeting, to look at what are some national certification criteria that we could adopt on a national level. We're still hoping that NQF picks up a national certification process because Washington State cannot do this alone, but they're still working on it. They're a couple years away, they said. And then in 2018, NCQA put accreditation guidelines for health plans into their book. They put in a new section about supporting population health. And we didn't even know about it, so we just found out about it. And they said, hey, they're supporting the use of certified patient decision aids. So if health plans provide the certified decision aids to providers, they get extra credit under the NCQA accreditation guidelines. We're like, great. We only have 5 certified at that point in time, so it's gonna be kind of a problem, but thanks for letting us know. So they kind of backed down on that a little bit and said, okay, in 2019, we'll say you can use certified or aids that have been developed with national certification criteria. We're like, okay, that'll work. But yeah, it's still a really good step in the right direction. And then also in 2018, National Quality Forum, they brought in a lot of experts and put together a shared decision-making playbook for communities to implement shared decision-making into practice, which is very cool. So now in Washington State, we've been working on shared decision-making since the early 2000s. The reason for that is Dr. Jack Wenberg from the Dartmouth Institute, he'd been doing a lot of studies on variation in care. So he came out to Washington State and he said, hey, Washington policymakers and healthcare leaders, you got a lot of variation in your state. So whether you lived in Port Angeles, up there on the coast, or down in Yakima, where we have a lot of migrant farm workers, you may get different care. You may be more likely to get care in Port Angeles versus down in Yakima. So what's up with that? So he said, one of the ways to address that is through shared decision making. So our policymakers listened, and so they implemented legislation to support shared decision making with the goal of reducing that variation without restricting choice. A lot of people, when I tell them this, are like, oh, you guys just wanted to save money, right? We're like, no, it was not about the money at all. It's really about supporting the residents of Washington State, which is really cool because policymakers, usually it's about the money, but this time it wasn't. So they say anyway, but they're still supporting that. So then the other piece that they put in was about the, was what I mentioned about the informed consent law, which was very cool. So that goal was appropriate utilization based on patient preferences rather than decreased utilization. So as I mentioned before, there's evidence that suggests that shared decision-making decreases overutilization or inappropriate utilization, but there's also been research that shows how it also corrects underutilization in specific populations, specifically in the African American population. There's been some great studies done about how in the African American population, they weren't getting surgical care that they needed. So when they were doing this study, they found that shared decision-making reduced overutilization in the white population, but it corrected underutilization in the African-American population. It's a fascinating study. If you're interested, I'm happy to share that with you. So we took the stance that we wanted to prioritize shared decision-making. Again, because we truly feel it's a key component of person-centered care. And so we've started putting it into our state statutes. So here's a little bit about what we did. 3 particular areas. We created a multi-provider shared decision-making collaborative. I mentioned group health. They took that on and they started a pilot. It was around total joint. That was in 2009. We established the BRE collaborative. I think that Jessica mentioned the BRE collaborative in her talk. The BRE collaborative, really, they were established to look at what are those critical guidelines, looking at the evidence. What they do is they give us, the healthcare authority, they take a deep dive into topic areas, and then they provide recommendations based on evidence to the healthcare authority so we can put it into our contracts to say, okay, this is how we want you to approach these different areas. Focusing on unwarranted variation and evidence-based improvement strategies. And then the third one in 2012, they gave the healthcare authority's chief medical officer the authority to certify patient decision aids, or at least recognize certifying entities meeting specific criteria. Again, hoping that there would be a national effort to certify patient decision aids. Again, no funding attached to any of this, but hoping that we would take this on. So one of the questions that we continually get is, why is it important to certify? So as we continue to push out shared decision-making and the use of patient decision aids as a practice, we recognize that as they become more widely used, the standards behind them become critical. Understanding that having standards ensure quality, and the quality ensures that the accuracy and the appropriateness of the information is that we can ensure that. And it supports the patient in exploring values. One of the things when we talk about patient decision aids, the value piece is so important and it needs to be there. If we don't have standards that say these are the critical components, we know that value piece will get lost quite a bit. Developers tell us time and time again that is the most difficult component to include in a patient decision aid. We say, tough, that's the most important component to include in a decision aid. So we appreciate that, but these are the standards. And we didn't create those standards, so don't blame us. It also minimizes bias. The thing about decision aids, when you have more than one decision that needs to be made, you want the patient and the provider together to look at all the information in a non-biased way so that it doesn't push them towards one decision or another. Also, for example, if that decision aid was developed with funding from, say, a pharmaceutical company, and the decision is to whether to take a statin or not, you want to ensure that that decision aid doesn't have any information about that drug company on there. So if they choose to take a statin, the provider doesn't say, oh, by the way, we're going to prescribe you this particular brand, or give you a sample, and that doesn't really work that way, but just saying that we want to ensure that we're not saying that drug companies can't support the development. We just need to ensure that there's no bias included in the decision aid itself. And that's the conflict of interest part that I just kind of went into that one as well. And then I mentioned that in Washington State, we provide enhanced liability protections as part of the certification. So our role at the state, we've developed this process to certify patient decision aids, but we also leverage our role as a purchaser. We're the largest purchaser of healthcare in Washington State, purchasing healthcare for 1.8 million Medicaid lives, as well as 200,000 state employees, PEB. Jessica also mentioned that we leverage that role to put requirements for ACP in our contracts with payers. So we try to leverage that role where we can. We've also provided training around shared decision-making and support to clinicians through a pilot that we did. And we're getting ready to roll out an online training around shared decision-making, kind of 101, to providers in our state. But it's a link on a website, so if anybody happens upon it, you can take it. It's fine, no problem. If you want the link, you can ask me afterwards. And then we've also been convening statewide discussions around how to spread and sustain this work in Washington State. So we developed this process in 2015, collaboration with a lot of local and national experts and stakeholders. Like Jeff Bezos, we recognized that we're not the expert in this. So we went out and found the experts. And we also were approached by the Gordon and Betty Moore Foundation, which that's kind of funny because I think you had to be funded by them to be invited here to speak. No, I'm just kidding. I think they seem to be everywhere, though. I think it's great. They do some great stuff. Actually, in 2014, when we were launching our SIM grant, we received a call from the Gordon and Betty Moore Foundation, and they said, hey, Washington State, we really like what you're doing to support shared decision-making, but you don't have a process yet. We would like to offer you funding to develop that process. And being state government, we never turned down money, and we said, sure, we'll take your money. And so we called all the national and international experts, and we brought them together, and we said, help us figure this out. And so they did. And so a lot of work went into this. We, as my old boss likes to say, we stood on the shoulders of many to develop this process. And we put together a process that builds on certification criteria that was developed over 10 years from the International Patient Decision Aid Standards Collaboration. So we adopted a subset of their criteria. And so the criteria that they developed is aimed at ensuring accurate, unbiased, up-to-date, and understandable information. And it addresses those values and preferences clarification. We also recognize that the criteria could be adjusted over time as we learned more about this process. And so our process is kind of a four-step process. When we first received the applications, and we've had 4 different rounds now, and we've been very specifically topic focused. And when we receive the decision aids from the developers for consideration, we initially do a review to see if they're patient decision aids or if they're actually educational material. Because if they don't have a clear decision, then they're educational material. So that's something to think about. If you have if you have material in your offices that you're using, if there is no clear decision, if it's just information about one particular area that provides risks and benefits, but there's no decision in there, that's more likely educational material. But if there's more than one decision and they're being compared, then that's a decision aid, most likely. So our review process, we do an initial review to make sure that they meet our first 6 qualifying criteria, and then it goes to a full review panel. This review panel, they review and score the application and the decision aid itself and supporting documentation against the certification criteria. They have to be really good in applying that criteria to that decision aid. They need to understand the full intent. So we brought in Dawn Stacy. She's a founding member of the IPDAS community to train our review panel. We bring her in every year because they need a refresh. So Jessica Martinson, she was on our last panel. She can speak to how it's difficult. It's not an easy process. So we try to keep the same panel and then bring in maybe a subject matter expert for that particular topic area. And then we've also, in the past, we've contracted with subject matter experts who also have an academic background to review the evidence. The developers are required to supply us with the evidence that they used to develop that decision aid. That's really important because these decision aids have to reflect the most current science and evidence. That's been a little difficult in the past because these are also subject matter experts who have full-time jobs. So we're very excited to say that this new round, we are now contracting with the Oregon Health Sciences University to do that evidence-based review. And so this is going to be their full focus, so we're pretty excited about that. And so their job is to review and score the evidence and the decision aid against the current science. So they validate the current science. But they also get to tell us, on a whole, what do you think about this? And then lastly, all of that feedback is given to our chief medical officer, who has the ultimate authority to say pass or no pass. So we don't have a rating system. It's not a Likert scale. It's a pass, no pass, or pass with recommendations. If the decision aids meet all of our certification criteria, and there's also a couple required criteria in the supporting documentation, we pass it. We may not like it, but we pass it. And then we provide additional feedback to the developers, which they take really seriously. And we always give them an opportunity to return it with changes if they would like. So here's kind of a visual of how this works. I just kind of walked you through it. The green box on top is sometimes we request additional information from the developer, or sometimes if we feel that they haven't met all the criteria, we give them an opportunity to cure, as our legal folks say. An opportunity to correct and send it back. They usually do. We've only had one developer decline to do that, and that's fine. And then at the end, for those aids that are certified, we post links for contact information on our website. Biggest question we get is, how come I can't find the decision aid on your website? Well, because they're proprietary, and most of them cost money. So we give you ways to contact the developers, to have those conversations with them too. And they're more than happy to talk to you and show you demos of their products. We do have one on there right now that is non-proprietary. And so in order to sustain our process, we've started charging for submissions. That's just to support the evidence-based review at the Oregon Health Sciences Center. But if you're submitting a decision aid, excuse me, that is non-proprietary, that is available at no cost, we waive that fee. So, just saying, if there's anybody out there who wants to develop one that's gonna allow people to use it at no cost, we will not charge you a fee. So the decision aids, the certification is generally good for 2 years. The reason we do that, and this is also in our law, is to make sure that there's a regular check-in about the evidence, because evidence is subject to change. Or if it changes dramatically within that 2-year period, we ask the developers to please submit that, any updates or change. We do have a shorter document that we ask the developers to fill out to say, has there been any changes? And if not, that's fine. We just change the date on it and recertify. So our first round was in 2015 for maternity care. We certified 5 decision aids. 2017, total joint, it was total knee, total hip replacement, and spine care, we certified 7. Last year, we did end-of-life care. We certified 24. Yay. I have to tell you, that was the most exciting certification round we had because it was such a different conversation than total joint. Total joint replacement was so scientific that when we had the conversations about end-of-life care, just very different conversations. We always have, what I didn't tell you is our review panel. Our review panel has our associate medical director on it. We have an RN on it. We have a health equity expert on it. And we always have a patient representative on it. And for end-of-life care, we had a family member. And it's just the conversation that, it was a very different conversation. So we've just closed our cardiac care one. We received 5. So end-of-life care is pretty cool because we received a lot. So as of today, we have 36 aids certified. So we had a lot of lessons learned, trying to define what we mean by adequately met when we say pass or no pass. We initially struggled with that. We finally landed on not letting the perfect be the enemy of the good, trying to decide what the threshold of what is good enough while still honoring the intent of the criteria. When it came to the bias piece and the balance piece, understanding there's always going to be a little bit of bias, but really landing on, is that bias harmful in any way? So we finally got to that point, and then thinking about how to eliminate bias with the reviewers, any personal bias. So checking your bias at the door up front before you start reviewing. That was always very important. And consistency of the reviewers. That's where the training was so important. So our evolution, first round, we updated the criteria to address health literacy. We've added in the patient and the health equity reps. We continue to refine and streamline the process, always ensuring we train, especially on the values clarification, and we've expanded our scoring parameters a little bit. So beyond certification, translating research into practice, we've implemented shared decision-making into contracts at the Healthcare Authority. With our accountable care program, we had a pilot, a maternity pilot, which has gone very well, actually. We provided support to 3 of our accountable care sites to help implement shared decision-making into practice, and we provided them with tools. And we have required shared decision-making and some bundled contracting arrangements around total joint. We're just launching a spine care one. Again, we mentioned we provided clinician training and convening statewide discussions. So let's talk really quick about the pilot that we did. So it was focused on using decision aids and shared decision-making around trial of labor after cesarean. So there were 3 sites. Each did it very differently, which was actually very cool because we could see the different formats and different outcomes. One was paper. They used a paper decision aid, one used an electronic aid, and then one just did a group class. They brought all of the women who were pregnant in that cohort in, and they talked to them together. There are varying degrees of EMR incorporation and varying baseline rates that they started out with. But what they did is they trained their clinicians, they implemented it into their workflow, and then there was a variety of maintenance and monitoring that went on. So here's the results. So the successes is they had really high VBAC rates and high satisfaction among the patients. Provider openness to doing the VBAC increased their uptake. There's a lot of provider engagement. while at the same time a little bit of frustration with learning new skills. But overall satisfaction with the training. Although it was a 90-minute training, there was a little bit of the time. And the group class approach was very positive. Recognition that shared decision-making can be incorporated into other areas to support women's health, I thought was the overall win there. So the challenges were around time, mostly around the time, the heavy workload, training, the cost of the decision aids, assumptions about shared decision-making. I mentioned that before. A lot of people assumed they were doing it already. A lot of providers said, why do we have to do this? This seems like something we should be doing already. And then implementation into the EHR was really complex. And then again, lack of high quality decisioning. So lessons learned, clinical champions are a must. Leadership buy-in is a must. Training is so important. Availability of the high quality decision aids is a must. Checking up assumptions up front with your providers, saying, do you feel you do this already? Because if you do, let's talk. Timing is really important and incentives are necessary. So here's what they said the value to their organizations were. The quality training, the decision aids help guide balanced, evidence-based discussions, and the value for the patient in understanding the evidence and the pros and cons. And at the end of the day, the process really helped elicit patient values and support-informed decisions. That, to me, was the biggest win. That's what we were really trying to test out. So for the future of Washington State, we're really trying to just continue to spread the use of decision aids, reduce variation in healthcare. We want to identify some measures to measure the quality and the impact of implementation. Continue to encourage submissions of different types, and at the end of the day, really engage patients in their decisions that impact their health. Encourage them to ask their providers for these things if they're not already. And that's it.
We have time for a couple of questions.
Okay. And that's okay. I get that it's Friday and it's still kind of early. You guys have hung in there all week. Okay.
What incentives are required? So when you say incentives are required in all this, what are the incentives? Can you repeat it, Laura?
Sure. So the question was what incentives are required. I wouldn't say incentives are required. I would say incentives would be helpful to providers to do this work. When we say incentives, I would say paying providers for the time to do the work, to do shared decision making, because it is extra work to have those conversations with patients. Providing them with these tools, these certified decision aids, because they do cost money. Helping them understand what shared decision making is and why this is important. So training is an incentive. Actually working shared decision making into an existing workflow, that's an incentive. So any incentive to providers to actually do it. I mentioned the extra incentive to providers under informed consent law. That's an incentive, but providers, I think, don't really see that as much of a benefit as just wanting to do the right thing. So, was that helpful? Sure.
Quick question, are other states contacting you about these efforts? It seems to me, here's my assumption, we're not going to see a lot of progress on the federal level to really impact how healthcare is delivered. It seems as if you are working very hard to really impact the quality and potentially the cost of healthcare, kind of really addressing variation. I'm sure other states face this, but are you being contacted by other states and saying, what are you doing? How could we do this?
No.
Okay.
I am being contacted by a lot of health plans. So I think that's very cool because our future is to really figure out how to put this into contract agreements with health plans to support providers to do this work. So yeah, unfortunately no, but go back to your states, have them contact us.
Well, that was kind of my intention, is to raise awareness here that, you know, we always look to the federal government to solve our problems, but we may be better off, particularly at this time, to do a more state effort. And you provide an example of a state effort which supports shared decision-making and person-centered care. So first, I applaud you for that, but I also ask people in this audience to think about how this might translate into their state health system.
We would love to help other states do this. Thanks, Bud.
Thank you, Laura.
Sure.